Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 10 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 5 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval.
So, good morning, everyone. I am Melissa Nadine Caraan, Mu Sigma Phi Sorority Batch 2015, speaking on behalf of the Aging and Longevity Webinars team of the Mu Sigma Phi Sorority. We are streaming live from the video conference room of the UP Manila Information Management Service, and our time in Manila is now exactly 12 noon. For today's webinar, we are privileged to have a distinguished alumna of the UP College of Medicine, Class 2002. She took her residency in adult psychiatry from 2003 to 2007 in State University of New York Health Science Center, where she also served as the chief resident from 2006 to 2007. She then took her fellowship in geriatric psychiatry in the same institution from 2007 to 2008. She served as the former president of the Philippine Psychiatrists in America from 2009 to 2011. Currently, she is an active consultant in Manila Doctors Hospital, Makati Medical Center, and the Medical City, and also served as a former attending psychiatrist at Sound Community Services, New London, Connecticut, USA, from 2008 to 2011. Ladies and gentlemen, we are honored to welcome Dr. Pia Natalia T. Reyes.
Okay. Thank you for that introduction. And also thank you to the Aging and Longevity webinar team of the Mu Sigma Phi sorority for the honor of speaking today. Today, I will be talking about depression and mental health issues in the elderly. I do have something to disclose. I am on the speaker panel for Zweilig Pharma. My talk seeks to answer the following questions. What are the unique positives and negatives about aging in terms of mental health? How do we better take care of late life mental health? And how do we diagnose and treat depression and anxiety in late life? As a broader overview, I will be talking about emotional aging, depression in late life, including suicide, anxiety in late life, diagnosis and treatment options, as well as some practical resources and advice for the primary care setting. So, first of all, why should we even talk about emotional aging? And what happens to our emotions as we age? This is because it's very important to be clearing up misconceptions. It seems only common sense to think that we need to have an accurate expectation of aging in order to age well. An overly optimistic picture often underestimates the challenges that many people face in late life and leave them ill prepared for planning for the future. On the other hand, overly negative expectations can become like self fulfilling prophecies, where people experience lower cognitive functioning and affective well being in response to their own low expectations in a kind of use it or lose it situation. In terms of emotions, there are positive aspects to aging. There is the well-being paradox, a term describing the remarkable phenomenon of older adults maintaining well-being despite physical decline and social losses. So there's this study by Charles et al., which examined negative affect or negative emotions, as we call it in psychiatry, across as much as 23 years. Negative emotions decreased with age, whereas positive emotions remained markedly stable. So, in other words, there was a much greater decrease in negative emotions, leaving the older adult with more positive emotions in general. Also, in contrast to popular belief, studies have shown that older men and women actually report fewer minor aches and pains than do young and middle aged adults, even though they have greater numbers of chronic illnesses. A recently done local study supported these findings. So, in psychosocial characteristics of successful agers among Filipino senior citizens in Quezon City by Pagay et al., 70% of respondents considered themselves successful agers. They were neither depressed nor anxious, had good quality of life, and positive perceived health, with no correlation found to the actual number of illnesses they had. So you could have a person with many illnesses, numbering seven, but they felt that they were a successful ager. And you can have somebody with very few illnesses, one or two, but they did not consider themselves successful agers because they were depressed. So they found, at least in the study, that there was no correlation regarding the actual number of illnesses to themselves feeling like they were successfully aging. These positive aspects to emotional aging is also consistent in the observation that mental disorders are less prevalent among older adults compared to younger adults. But this does not include neurocognitive disorders. Okay, if you can look at the slide, the topmost bar represents the prevalence of psychiatric disorders in over 65 in each category. And as you can see, it is the smallest bar in all of the categories. However, there are also negative aspects of emotional aging. So, older people may experience life stressors common to all people, but also experience stressors that are more common in later life, like a significant ongoing loss in physical capacities and a decline in functional ability. In addition, older people are more likely to experience bereavement or a drop in socioeconomic status with retirement and loss of income. All of these stressors can result in isolation, loneliness, or physical distress, psychological distress in older people. In addition, older adults are also vulnerable to elder abuse, including physical, verbal, psychological, financial, and sexual abuse, abandonment, neglect, and serious losses of dignity and respect. Epidemiological studies have confirmed that although major depression is less common among older adults than among younger adults, depressive symptoms associated with impairments in functioning may be common in late life and increase with advancing age. So these are symptoms. You're not fulfilling the criteria for the disorder yet. But the symptoms, just the few symptoms, can be associated with impairments in functioning already. Across various epidemiological studies, the estimated prevalence of minor depression or clinically significant depressive symptomatology among community dwelling older adults ranges from 1 to 49%. And so, at its worst, that is half of all older adults experiencing depressive symptomatology. And so, keeping in mind a balanced and realistic view of emotional aging with positives and with negatives, it becomes very important to do a comprehensive geriatric assessment, taking into account the level of functioning and independence of the patient, their quality of life in all aspects of their life. Please do speak and involve family members or caregivers in the assessment, and older adults should be screened for depression when appropriate support measures, meaning the presence and availability of mental health professionals such as psychiatrists and psychologists, are available to ensure accurate diagnosis and effective treatment and follow up. In addition, in the primary setting, it has been recommended for physicians to use a stepped care approach. So, this is where, in cases where the patient is screened for mental disorders and falls short of fulfilling criteria, but the index of suspicion is high, increasing the frequency of follow up and watchful waiting can be helpful to decrease morbidity of mental illness. For the patient, we can recommend increasing social activities. So, Forsman et al. In 2011 did a systematic review and meta analysis of prospective controlled trials looking into psychosocial interventions for the prevention of depression. In comparison to no intervention controls, social activities were effective in reducing depressive symptoms, but results should be interpreted with caution. How the patient will increase the social activities will be up to you, the patient, and the family caregivers, and how you talk about it in your clinic, usually in a brainstorming or troubleshooting fashion. Also, for the patient, we can recommend increasing physical activity. In addition to benefits for physical health, growing evidence indicates that physical exercise may enhance cognitive and emotional functioning. This slide shows the epidemiology of mental disorders in older adults. It can be seen here that the most common category of psychiatric disorders is anxiety disorders, followed by mood, in particular depressive disorders. So, going straight to depression, I'm sure you all know this, but it always bears repeating that depression is not a normal part of aging. The prevalence of major depressive disorder in older adults has been estimated at anywhere between 7.2 to 38%. And in the Philippines, a cross-sectional survey of a random sampling of older adults over 60 in Rizal province estimated the depression at 6.6%, but could be as high as 26.5%. And depression, presenting as either a chronic depressive symptom or a first episode in late life, has been identified as the most powerful independent risk factor for suicide in old age. In the US, the highest rate of suicide is in the age group of adults over 65 years of age. In the Philippines, that is not the case, as the highest suicide rate is still in the younger population. So if you look at the green triangles and green circles, that's the population over 65. However, as of 2011, the rate of suicide appears to be rising in the older population. The following are known risk factors for depression in older adults: bereavement, sleep disturbances, disability, prior depression, and female gender. In patients with late life depression or first episode depression in late life events precede the depression in more than 50% of the time. It has been recommended that at the primary care level, we should be screening for major depressive disorder in older adults. And the quickest way to screen would be to use the PHQ-2, which uses the most important two questions from the original PHQ-9, which are: how often in the past 2 weeks have you been bothered by little interest or pleasure in doing things? And how often in the past 2 weeks have you been feeling down, depressed, or hopeless? The purpose of the PHQ-2 is not to establish a final diagnosis, and it's not to monitor depression severity, but rather to screen for depression in a first step approach. Patients who screen positive should be further evaluated with the PHQ-9 to determine whether they meet criteria for a depressive disorder. So, PHQ-9 or any other depression scale. Of course, the gold standard remains the actual DSM-5 criteria. For obvious reasons, the PHQ-9 is more sensitive and specific than the PHQ-2. However, there may be some older adults who have a hard time recalling how often certain symptoms occur. And so in these patients, it may be easier to use the geriatric depression scale, which asks questions in a yes or no format only. And this is easily available online. In addition, the GDS has been validated in patients with dementia. Older adults are also more likely to complain of poor memory, concentration, decreasing processing speed, diminished executive function to the extent that the patient may be presenting with symptoms similar to a major neurocognitive disorder, also known as pseudodementia. These symptoms tend to resolve as the person's mood improves with treatment, unless there's a comorbid neurocognitive disorder. Studies suggest that depression itself increases the risk of developing major neurocognitive disorder by twofold. In the diagnostic evaluation of depression in older adults, it is important to know the following: suicidal ideation, psychotic symptoms, the presence or history of manic symptoms, substance use, and cognitive problems. Although it is important to rule out medical problems as a cause or contributory to the depressive symptoms, we have to realize multimorbidity is the rule in this age group. If there is any of the above, or when in doubt, please refer. There are now more treatments available for older adults with depression than ever before. Certainly, the mainstay pharmacological treatment are the antidepressants. And the talk therapies for depression are well established. So I have listed here cognitive behavioral therapy, interpersonal therapy, and behavioral activation. In addition to all of these are the neurostimulation treatments, such as ECT and RTMS, or electroconvulsive therapy, and repetitive transcranial magnetic stimulation. There are more of these neurostimulation treatments that have been approved, but these are the neurostimulation modalities that are available in the country at this time. Late life depression is often inadequately treated, with majority of patients receiving no treatment at all, receiving lower than recommended doses of antidepressants, or being treated for too brief a period. Also, recent life events, coping with functional impairment, or having a lack of social contacts are examples of psychosocial factors that are frequent contributors to depression among older adults and should be addressed as part of treatment planning. The SSRIs, or the selective serotonin reuptake inhibitors, are listed as first-line treatment in many guidelines, even in the frail older adult. Please note that in general, low dose reduction is necessary in the older adult compared to younger adults. This also applies to the SNRIs, or the serotonin norepinephrine reuptake inhibitors, as well as the other mixed receptor newer antidepressants. The response rate of antidepressants in older adults is generally thought of to be similar to the younger patients, about 30% response rate with placebo and 60% with treatment. It is important that when you prescribe antidepressants that you feel you have mastered the side effects so that when you prescribe them, you can prescribe them with confidence. And that really matters when dealing with patients with depression. Okay, so moving on to anxiety in older adults. Anxiety is a normal human emotion, but pathological anxiety is costly. It can lead to a diminished quality of life and is related to many other medical diseases, including cardiovascular diseases. Detecting pathological late life anxiety is often complicated by normal aging, challenging life circumstances, including bereavement and disability, minimization of symptoms, the presence of other comorbid medical conditions, more frequent somatic complaints, and potentially cognitive impairment. Most studies conclude that generalized anxiety disorder and phobias are the most common anxiety disorders among older adults, with panic disorder and social anxiety disorder or social phobia less common than in the younger age groups. Rates are higher in the special groups like patients with heart disease, atrial fibrillation, COPD, and Alzheimer's disease. So, this is just a review. Generalized anxiety disorder is diagnosed by the presence of excessive anxiety or worry on more days than not, lasting more than 6 months. We also need to have three or more of the following symptoms, such as feeling restless, keyed up, on edge, feeling easily fatigued, having difficulty concentrating, mind going blank, irritability, muscle tension, and sleep disturbance. There should also be clinically significant distress and impairment in important areas of functioning. Specific phobia, on the other hand, should have marked fear or anxiety about a specific object or situation, lasting more than 6 months. The phobic object or situation provokes immediate fear or anxiety, is actively avoided or endured with intense fear that is out of proportion to the actual danger. Again, there has to be clinically significant distress or impairment in important areas of functioning. Fear of falling is a geriatric specific syndrome. It can be conceptualized as a specific phobia that is known to impact older adults and can lead to significant functional impairment. Disorders that involve the fear response, like panic disorder, are thought to have a particularly low incidence rate in the geriatric population. Therefore, any new onset panic disorder in late life should prompt a thorough search for alternative and comorbid diagnosis and close attention to systemic medical conditions and medication side effects. There is a very high comorbidity between depression and anxiety. In addition, anxious depression in older adults appears to represent a subtype of depression that is relatively treatment resistant, associated with an increased risk of neurocognitive decline, and maybe more importantly, an increased risk for suicide. So this table just lists very commonly known risk factors for late life anxiety disorders. The diagnosis of anxiety disorders requires careful and comprehensive assessment of the patient, including a clinical history, physical examination, and laboratory investigations. There are many things that will complicate assessing an older person with anxiety. Okay. Unfortunately, there are patient related factors that contribute to the difficulty of making an anxiety disorder diagnosis. This include the lack of self-help seeking behavior in older anxiety patients, effective avoidance behavior, and so if you have effective avoidance behavior, you don't get your symptoms. It will not be seen. And that older adults are more likely to attribute anxiety symptoms to medical problems. But there are also physician and caregiver related factors as well that contribute to the difficulty in diagnosis. Ageism is probably involved in the fact that anxiety and avoidance behavior in late life is often interpreted as normal or realistic, and therefore deemed untreatable. Also, because medical comorbidity is more common in late life, the physician is inclined to assign a high priority to the appropriate diagnosis of a medical problem, which is a good thing. However, after you've done that, the diagnostic inquiry often stops. The easiest way to screen for generalized anxiety disorder would be to ask, are you a worrier? And if yes, is it hard to stop the worrying? And the easiest way to screen for specific phobias would be to ask, are you afraid of blank? And you just fill in the blanks. It is best to ask directly, especially with older adults, ask directly about everything, including fear of falling. I have included other screening questions here for other anxiety disorders for your reference. After diagnosis, a treatment plan should be developed in collaboration with the patient. And the main thing I want to emphasize is that there should be an emphasis on realistic goals. Therefore, do not promise the patient that you will be able to remove all anxiety symptoms. Rather, you will make the occurrence of anxiety feel more tolerable and manageable and thereby minimize suffering. It is generally thought that pharmacological treatments are more useful in generalized anxiety than in specific phobia. However, non pharmacological treatments or therapies are useful in both. Please minimize polypharmacy and please optimize current medications. This table is similar to the table on the treatment of antidepressants, of treatment of depression. And so please just refer to that table. In general, the doses and duration of these medications are similar to those of younger adults. What about benzodiazepines? While benzodiazepines can provide short-term relief of symptoms, their use should be limited to cases of extreme suffering, and even then, should be used in a scheduled, time-limited fashion because benzodiazepines reinforce maladaptive coping behavior. So the rule of thumb is don't take off unless you know how to land. So basically, don't start a medication if you don't know how to stop it. This is a resource I frequently use for my patients with anxiety. The Anxiety and Phobia Workbook by Edmund Bourne is primarily CBT based, but it is very useful for psychoeducation. This book is also what I recommend to my patients who have the patience to read. I encourage you to get one book on mindfulness and read through it to give you an idea about what it's all about, although some patients find more benefit with apps such as Headspace, Calm, and Insight Timer. When you are looking to refer a patient for a certain therapy, I have this advice for you. Therapy referrals are not centralized, and many are discovered by word of mouth, even by fellow psychiatrists and fellow clinical psychologists. In general, therapists in the Philippines practice an eclectic approach. This means they receive some training in some therapies, but may not be certified in any particular one. Certification needs time, money, and supervision to achieve, which not all may have access to. A therapist could be excellent, but not certified. As much as possible, check the training of the therapist that you are thinking of referring to. But also bear in mind that the fit of the therapist to patient can be as important as the training they receive. Ask your favorite psychiatrist, and if you don't have one, get one, for who they know and how to get to the therapist that they like. In terms of therapy centers, no therapy center specifically caters to older adults. However, the Bulatao Center in Ateneo de Manila does specialize in mindfulness, and there are many other psychology therapy groups that specialize in counseling, and I've only listed a very few here. In the interest of time, I'm skipping my summary and giving it back to Dr. Caraan.
So thank you very much, Dr. Reyes-Sia, for that very comprehensive talk. We now have 34 viewing through UP Manila live stream, 69 through YouTube Live, and 616 through Facebook Live, and groups viewing from all over the Philippines. So that's more than 700 people listening to our talk right now. So the floor is now open for questions from the audience. Just type in your questions at the Q&A chat box in the right lower corner of the live stream window, or type in comments in YouTube Live or FB at Aging Webinars for Facebook Live viewers. Okay. So we have our first question. Aside from suicide, what usually is the cause of death from depression without pathologic cause?
Okay, that's a very good question. A lot of times with depression will come lack of loss of appetite and problems with sleep. So actually, the depression increases the burden of the disease of whatever they may already have. So let's say they have hypertensive disease, they have chronic kidney disease, they have diabetes. All of these other issues will worsen first, and eventually they become the common cause of um, the demise of the patient. In some cases, especially when it's very frail, the loss of appetite that occurs initially is very difficult to get back even after treatment because everything has atrophied. You know, the muscles, the swallowing muscles have atrophied, the tongue has atrophied, and so therefore they cannot eat as much as they used to. And the malnutrition becomes the cause of demise.
Another from the same
Okay.
viewer. Can the aged die just by willing to die?
Okay, I'm not sure if there are any studies about this. Um, I would imagine, though, that a uh, there's something called the nocebo effect. Okay, and there have been great studies about how people believing that they're going to die just kind of drop dead. So there are case reports about this. So unlike the placebo effect, there is this nocebo effect. If you believe you will have a negative outcome, you will certainly have it. I don't know how well studied this is in terms of death and in terms of older adults. I imagine it can be possible. I have not seen it personally myself. Usually there is a medical issue. I mean, I have not yet seen an older adult perfectly healthy willing themselves to die. Usually there is something wrong already. They have arrhythmia, they have a heart attack, and certainly high stress in any situation can induce a heart attack or a stroke, and therefore they may have willed it to will themselves to die by subjecting themselves or allowing themselves to experience that level of stress. But it's a good question. Maybe it can be a good study.
So another one. I think a big problem is convincing the senior to see a psychiatrist. What can we say to convince a senior?
Well, one of the things, well, it really depends. What I usually advise is if people are open to talking about depression and anxiety and not equating it to what older adults fear, yung mga siraulo or psychosis, even though they may be that, even though there could be psychosis, if people around them are willing to discuss it and willing to subject themselves to similar evaluations, the older adult usually can be persuaded to go. Sometimes you will have a very stubborn older adult. Usually they are the men, the older men who are like big shots wherever they were. The head of a company, the head of the family, and usually they also have a personality sort of embedded in their personality, a certain kind of rigidity and pride, maybe, and denial. In some cases, I just try to coordinate with a family practitioner that they always see anyway for their heart condition, usually, and see if that other person can be the one to either treat directly or to introduce the idea of a psychiatric referral.
Another question. This one more biologic. Are there any studies that sertraline helps post-stroke depression among the elderly? How about the regain of motor activity post-stroke? Does it help?
Okay, I'm not sure if there's. Wait, no, that's not true. I believe there is a sertraline study regarding post-stroke, but I can no longer remember right now the findings. The biggest study that was ever made looking at antidepressants and the post-stroke state was actually by rehab medicine, and that was using fluoxetine and compared to nortriptyline. And they did find that regardless of the presence of depression, that it improved recovery post-stroke. So that's one of the reasons why you may see your neurologist just prescribe it out of hand after that study came out, because it was a very big study, very comprehensive. I think it was a Japan study. It was done in Japan. So about sertraline specifically, I know there is one, but I can't remember the results. My apologies.
Okay, another question. Can you self-claim that you had anxiety and depression without ever seeing a doctor?
Um, it's your right. You can certainly say whatever you wish. And I actually wouldn't say, I mean, if somebody says that, I would actually really listen. Because a lot of people, maybe a decade ago, would really downplay such feelings. And if, for example, you have someone who ordinarily by personality likes to complain, let's say, there's nothing to say that they didn't actually have depression and didn't have anxiety either. Just because they like to complain doesn't mean that it's not there. So it's very possible. So it may bear some looking into, um, and and see. You never know what will happen when you ask the right questions. Um, yeah. Okay.
Okay. So, are elderly staying in a nursing home more prone to depression or mental illness than those elderly who are being taken care of by their own families?
I can give you the U.S. data. I don't have the Philippine data. In the U.S., guaranteed nursing home patients have higher incidence of everything. Higher incidence of depression, higher incidence of cognitive dysfunction, higher mortality rates. Everything is higher in the nursing home compared to what is phrased as community dwelling older adults, even those who have many medical problems. So usually in the United States, what they would say is, if they land in the nursing home, well, the clock is ticking. They don't have that much time now because everything is just going to increase there. In the Philippines, however, I think what we don't fully know is the interaction between caregiver fatigue, the social isolation, because even if they're at home, the caregivers may not necessarily be the family. And in that situation, there may still be a great sense of isolation, and how that interacts with their health. I do have experiences of family members being all in different parts of the country, in different parts of the world, and that really impacts on the care of the patient. Um, so we don't know that. We don't know that for us, and we don't know that for here. So we only know in the US, yes, rates are higher in nursing home patients.
Another one, um, I think it's a follow-up of sertraline. Is it dangerous if you are on long-term use of sertraline?
Okay, dangerous. See, it all depends on what you mean by long term. You will have long term patients who started on sertraline maybe, let's say, in their 20s. Okay. After about the first 10 to 20 years, you will become at higher risk for like bone loss and osteoporosis. Um, and so there is that long-term risk. And usually we try, if the patient really needs to be on an antidepressant for that long, let's say because of many reasons, we recommend bone scan early and regularly so that we can detect osteopenia. In the older adult, the incidence of a recurrence of a major depressive disorder tends to be higher than in a younger adult. And so the tendency will really be that the older adult will stay on the antidepressant for longer than a younger adult. So sometimes the recommendation is, instead of just 1 year, extend to 2 years. Because, and also because, as we've said before, the impact of depression in the older adult can be bigger, even if it's even if you have the same score, for example, on rating scales, same score, younger adult, older adult, but you can have a greater impact on the older adult because they're sicker and frailer. So you really have to weigh that. So when you say long term, in the older adult, the major issue is just really making sure that the sodium is normal, okay? That there are no blood issues like blood thinners and things like that. Um, and that person is always goes to their primary care physician to make sure that everything is okay with them. Okay.
So a lot have been asked about sertraline, and now the question is, what is the best treatment for major depressive disorders?
Okay, the best treatments. Okay, so you're not talking about the antidepressants specifically. The combined treatment, combination treatment of set of therapy and antidepressants are always the will always give you the best outcome. Okay, so if you're looking at moderate to severe depression, you have to do your best to get both on board. That's not always that easy because you may have somebody who only wants therapy and you may have somebody who only wants an antidepressant. But really, the best is both. Okay, so I'm not going to, and of course, the therapies I've already mentioned, these are well established. And behavioral activation, although it spans a lot of individual skills and techniques, it's also exercise. So if you can get a patient to make these life changes, it will go a long way to treating their depression. Did that answer the question about?
Yes.
Okay, okay. So, yeah.
Okay, another question. Can a personality disorder like narcissistic personality contribute to depression?
Well, of course, yes. And yes, of course. Parang yes or no lang yung question eh.
Yes.
Um, if anything, narcissism or narcissistic personality disorder has a greater contribution in a person not wanting to get treatment. And in that way, it gets really messy. In the cases where a narcissistic person is willing to take to be in therapy, be in treatment, it's not as bad. But certainly, yes, it can. Okay.
Another one. How can we motivate the elder patients to be productive as he or she were before she got depression with limited therapy provider here in the Philippines?
Okay. So so prevention again is the best policy. So I try whenever anyone asks me should they retire, I say no, don't retire. As long as you like the work and it is not a large source of stress for you, stay in the job as long as you can. And if you have to retire, like in government situations where there's mandatory retirement, years before your retirement, already have something set up for yourself. Or if you are a concerned child or relative of a patient, already have a list of things that the patient can do so that the transition between work and life after work or retirement is not so hard. It's usually within the first year of retirement that they have, like, they have fun because they get to do whatever they like. Then afterwards, boredom and social isolation starts to set in. And sometimes they really need help in organizing this. So if a person is already depressed and the motivation is low, it's very difficult. And that's why sometimes the antidepressants come in very handy because it really gives them that extra uplift so that they can start doing other things. Um, uh, Sometimes it helps to just really drag them, take them by both hands and bring them to a senior center, bring them to a large gathering so that they can be energized in spite of themselves. And because we kind of underestimate the ability of peer pressure in older adults. If the people around them are happy and are in a party mood, their mood will also improve. That is the way we are designed. And so, and this even works for people with dementia. If you want to decorate the house in balloons and flowers all the time and like sunflowers or whatever, and I've seen that. I had a patient and yung favorite niya, it's all over the place. The mood improves. So we can think out of the box in terms of those environmental changes. And of course, our own selves, showing them how happy we are when we're with them and in convincing them, come on, let's go to this party, let's go here, let's go there. And then that starts already the first, that takes a few steps already to getting better.
Okay. Another question. Have you encountered many of your patients who were diagnosed with low vitamin D and the management of depression? Did it improve with vitamin D supplements?
Okay, so first of all, I have not actually, um, it's not my practice to screen for vitamin D. Okay. I have not specifically prescribed vitamin D. So perhaps after your question, I'm going to look into the data. Um, there are some people, I'm not sure the incidence of vitamin D deficiency in the Philippines, given that we're exposed to so much sunlight. Um, uh, Even in the United States, even on supplementation of vitamin D, however, I did not see a very big change in the depression. I do not know if there was a sort of a cohort effect that occurred because when I was training there and seeing patients there, it was also the recession. So a lot of people were out of work, and no matter how much vitamin D you give them, they're still out of work. So parang hirap lang talaga. So I really, and it was mahahaba ang winter. It didn't really matter that much. Incidentally though, phototherapy helps. So that more than the vitamin D supplementation was better for depression, in my experience.
For anxiety disorders, is there a higher prevalence of anxiety in high functioning individuals?
I'm not sure if there are any. Wait. Sige, sige. Let me phrase this. Anxiety disorders tend to occur in patients who have a high trait. So this is not an illness, a high trait of neuroticism. And from neuroticism is born out perfectionism, obsessive compulsive behavior that in our current culture we like. Okay, so in a way, this becomes a kind of adaptive thing for our culture to become kind of neurotic and obsessive. And therefore, we see these people as high functioning because that is what our culture right now likes. Okay, so in that sense, I will say yes, because it is a risk factor for anxiety disorder. But high functioning per se, perhaps you could have a person who's high functioning but is not neurotic, and that person may not necessarily, or that group of people may not necessarily have a higher incidence of anxiety disorders.
Another question regarding post-stroke patients. Uh, you talked about pregabalin as adjuvant therapy. Now, in post-stroke patients with neuropathic pain and depression, do you recommend to use amitriptyline, the Loxotin capsule versus pregabalin?
Okay, pregabalin. I haven't actually, I didn't actually mention pregabalin, but that's okay. Pregabalin is for anxiety. It can be used as adjunct for anxiety, as is gabapentin. Uh, the Do I recommend it? I mean, you can certainly use it. In the study that looked at rehabilitating the post-stroke patient on either fluoxetine and nortriptyline, the interesting thing about fluoxetine kasi is it's one of the SSRIs that has the strongest norepi. So, serotonin na nga siya, yes, SSRI siya. Pero of them all, siya yung may pinakamalakas na N. Okay, and so in that way, it was kind of similar to norepinephrine, to nortriptyline, and in that sense, to duloxetine and to amitriptyline. So you're looking at these mixed receptor antidepressants. Uh, the thing that I would worry about in terms of the amitriptyline would be the high anticholinergic effects of amitriptyline. So it can worsen kasi their cognition. So I wouldn't actually, that's why they use nortriptyline kasi medyo clean yung nortriptyline versus amitriptyline. And fluoxetine, to be fair, okay, certainly you can use that. But there are people who have increases in high blood pressure. So if that's something that you're watching out for in your post-stroke patient, perhaps it wouldn't be my first line. But if that particular person has been on duloxetine in the past and you know that their blood pressure did not increase, then why not? You can certainly give it.
Okay, so is it okay to take St. John's wort for treatment of depression?
First, it depends on how old you are and how many comorbids you have. Because St. John's wort has a lot of cytochrome interactions kasi. And it's hard to dose. You know, we don't have dosing strategies. If you are younger, relatively healthy, I would certainly go ahead, try. I would advise you to be very systematic about it. You know, like figure out your dose, what works for you, buy only from one source so that the concentrations are always the same. And then, you know, make yourself your own study, your own research so that you have, so at least you're safe, right? You're safe with that. I wouldn't really recommend St. John's wort to anyone, for example, in a post stroke. I really wouldn't recommend it to anyone over 65 with medical comorbidities. Probably not. But certainly a younger person, you can always try.
So another one, some of the retired patients doesn't want to get out of their homes. So how can we increase their activity at home if they are not willing to go out? Or how can we encourage them to go out and have an activity which they like? And for the activities at home, what's the best physical activity that they can do?
Okay. Um, my first advice would be take time to really get to know your older person. Okay, because these people had a life before they were stuck at home, and try and see what it was that they liked. You know, did they like, what were their hobbies? What kind of people were they? Sometimes you will come across an older adult whose life was their work. And when the work ended, parang pati yung life nila nag-end. And then you, if that's the case, you really have to stretch even further than that. You have to figure out what their lives were when they were in high school or when they were, you know, teenagers, the things they like, the movies they watched, you know, the music, those things you have to get to so that you can figure out what will appeal to them the most. Okay. In terms of, and sometimes even then, you're not going to get them out. And maybe antidepressant na lang ang katapat niyan. Maybe. Okay. Or if you really haven't had an evaluation, maybe an, you know, an anti-dementia medication because sometimes it's already dementia, what you're seeing. In terms of exercise, anything that will get them moving, will take it na. You know, kasi if they're going to start from a very deconditioned state, whatever they're willing to do, gawin na lang nila yon. If they want to talk about 5 minutes of exercise, no problem. Kasi later, the 5 can become 10, can become 15. Pero if you start them off kaagad, kailangan aerobic, ganito, 30 minutes. Ayaw na yan. Kasi they're really going to be tired. So whatever they're willing to do, even if it's just walking around in sort of large circles at home, if that's what they like, game. Try to involve as much of the body as possible, like arm exercises as well as leg exercises. And then you start from there. Ideally, they should be seen by a rehab medicine doctor to recommend sort of the best for their body type and for their medical problems. But at the beginning, whatever they're willing to do, gawin na lang nila. You know? Kasi you just really need to start, and that's the hardest part.
Okay. So this one is a personal question and in behalf of the primary healthcare
Okay.
physicians. Majority of the Filipinos don't really have access to laboratory workup. So if they are presenting with anxiety symptoms, is it prudent to start anxiolytics on them, especially with the geriatric population?
Okay, so number one, please do. Wait, hold on. We have to make sure. I'm assuming, okay, with your question that you have done a complete history
Yes.
and a complete physical.
Physical.
Okay. You can always do a trial. Yes, it can be safe to do it. However, my biggest worry is the older they become, the more likely the sodium will fall. And that is going to be like confusion and all that stuff. So you just have to be willing to see the patient regularly, like weekly, kung kaya. And most primary care people cannot, can't afford that kind of time. So if you can, it gets scary that way. So you may want to lean towards the like let's say behavioral activation, getting a concerned caregiver to read about what they can do, yung mga thought challenges nila and those things, rather than commit to an antidepressant that may give them a side effect that you cannot address quickly enough, that might cause them to, like, die or fall. Very scary. But you can. I'm sure you'll have such a patient, right? No medical problems, magandang blood pressure, nothing. Oh, so you can always try, but just be very careful.
Another one.
Okay.
Majority of the senior citizen programs that are health related are towards maintenance of antihypertensives and pneumococcal vaccines, but none on the mental health. So, would you suggest that senior citizens are periodically screened for depression?
Um, yes, I would like. I think it would go a long way if the senior citizen can be screened. Okay, if there were interventions that can be put in place at the community level to address the depression, because you could screen for it and then wala rin mangyayari kasi no one is there to treat them, and there's nothing there to help improve their current life situation. So I remember the QC study that I mentioned earlier was very interesting because apparently elderly people in QC are very active at the barangay center level. So that already will go a long way in keeping the seniors healthy. And maybe that's why maganda yung data doon. Di ba? Maganda yung successful agers doon kahit pangit yung physical status nila. Kasi nga, they already are at the senior center and they were very active. And we need to have that kind of cultural change in our minds na the government shouldn't just provide us with, screen this, vaccine that, check blood pressure, but also provide our older people with a place to be and things to do that will help them to have meaningful lives.
This one is a very timely question. So, okay, so this will be the last question because of time constraints and also a very timely one. Every Christmas season, we go to our home for lolos and lolas. We sing for them, dance with them. You can see in their eyes and their faces that they are very happy. But when it's time to say goodbye, you can see the changes in their faces, that they are sad and almost crying. Could activities like this promote depression?
It's not that the activities promote the depression. It's the loss of your presence. So actually, when you see them crying, that's more or less how they are when you're not there, and they get happy when you are. Okay, so if you took that away, like if you took the Christmas celebration away, they will even be worse. So it's not that am I making sense?
Yes.
Tama ba? Okay. So, technology is amazing now. There's always Skype. There's this Facebook live stream, right? And so these are ways to remain connected to our older people. We just have to figure out a way that we can do it regularly. I always suggest daily, and if not daily, regularly, several times a week. Because that is what is necessary. They need to see our faces. They need to see our faces. We need to see their faces. Something happens in a subconscious, and I'm not meaning like Freud kind of a way. There's something happening really in the nonverbal behavior of when you see somebody who is happy that changes how you feel inside as well. And that's very important. And no one is more affected by it than the older adults, especially those na medyo nawawala na yung frontal lobe. Yun na medyo nag-disconnect na. Mas lalo pa silang naapektuhan. So that's why when you're with an older person, try not to be down. Kasi they're gonna be down also with you. You have to be kind of upbeat. Para sila rin upbeat, madadala mo sila. Yun. So, frequency, and giving them something to be happy about throughout the year, not just Christmas, will go a long way to helping them and preventing depression in those older adults. Okay.
So once again, thank you for all the questions that you sent. And thank you so much, Dr. Reyes Sia, for enlightening us with your answers.
Thank you for having me.
Thank you, ma'am. So in summary, we'll learn from the webinar today that number one, Older people are able to maintain quality of life and well-being despite physical decline and social losses. Majority even consider themselves successful agers. However, psychiatric disorders still present in the elderly, most commonly anxiety and depression. These conditions are often overlooked and may be comorbids of each other. It is suggested that social activities and physical exercise are recommended for the older people as they have been seen to reduce depressive symptoms. Number four, pharmacologic management like SSRIs and non-pharmacologic intervention like cognitive behavioral therapy or behavioral actuation are readily available and should be maximized. But when in doubt, always refer. So with that, we would like to thank Dr. Pia Natalia Reyes Sia for taking her time out of her busy schedule and sharing her expertise with us today. Thank you, ma'am.
Thank you, Dan. Okay. And you're welcome.
So for those who missed the lung cancer in the elderly webinar, we are bringing it back for Lung Cancer Awareness Month this November. It will be held at 6 p.m. on November 27, Wednesday. Please join us again on November 29 for the Parkinson's disease webinar by Dr. Joy Antonel R. de Marqueda. And please also join the UP Med webinars every Wednesday. Stay tuned for some additional reminders.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Phi Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. To receive your certificates of attendance, kindly answer the evaluation through the link that will be sent to your email addresses after you sign the attendance sheet for today's webinar. The certificates will then be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at YouTube at Aging Webinars channel. We are also announcing the launch of the OB Pearls book. Get your copies now. Thank you and have a great day.